Dr. Beth Schenk, who serves as the Executive Director of Environmental Stewardship for Providence, which is one of the nation's largest nonprofit health systems. He works towards Providence's goal to become carbon negative by 2030 through strategy and innovations, conservation of resources, by improving efficiency of practices and processes, and through education and research built on her experience decreasing the environmental impacts of healthcare for over 30 years. Dr. Schenk is an assistant research professor at Washington State University College of Nursing. She serves on the board of the national organization, the Alliance of Nurses for Healthy Environments, the state organization, Montana Health Professionals for a Healthy Climate, and the local organization, Climate Smart Missoula. So she's very busy. She is also a fellow in the American Academy of Nursing and is a member of their expert panel for environmental and public health. And with that, please welcome Dr. Beth Schenk.
Thank you all for coming today. This is really wonderful. And as mentioned, I'm on the board of the organization supporting this. I've been working at this for a long time. In fact, when Dr. Patel was talking about her sort of conversion experience, I was thinking, I remember the day and the location I was when I took climate change seriously. It was in my house in 1996, and a visitor was coming over from the Climate Reality Project. He was visiting us. And I had heard about climate change and I knew, yeah, that's true. But I was working on other stuff in environmental issues, including recycling at the hospital. I was on the board of MEIC at the time, doing things like that. And I remember thinking, I better pay attention to that. Years later, in fact, 8 years later, after I'd been working in the area of environmental stewardship for a while, I was frustrated and I knew I needed a change. Frustrated that I couldn't do it enough. Frustrated that I still was working, doing other stuff that felt a little bit already as a distraction to me from what felt like my more urgent work, which was this. So I was on a trip to New Zealand, and there's two islands, as you know, North and South. South Island on the northwest corner has a little thing called the Farewell Spit. And so I was walking out there and just by myself and had this conversation with what I called at the time mentors. And I just was saying, I really want to figure out a way to do more of this work. I don't want to just be distracted. I don't want to feel like I can't get to what I think is most important. And so I said to myself, I will follow your lead. I will pay attention, listen to signs and hints. And I walked back from this little, just 2 or 3 mile walk. And I felt a little better, like I'd kind of, identified some source of angst for me. But it wasn't until about 5 years later when I realized how much had changed in my life. And I said, wow, is that because I had this sort of commitment that day in 2004 on the South Island of New Zealand? Maybe. I don't know how these things work, but I do know that really was a change for me. And ever since, I've been able to zero in more and more on what I feel like is this very important aspect of what I do specifically. It's responding to what Dr. Patel said in terms of the conditions out there, but looking specifically at healthcare. Because I've had 30 years experience in operations and understanding how hospitals work and understanding a bit about purchasing and HVAC and that sort of thing. So that puts me in a good position to do this. So I feel very, very grateful for that opportunity. I feel like I can pretty much do it full time. And then plus with the 3 boards, et cetera, I was trying to kind of calm down, but I'm not very good at that. So next slide, please. We're doing this because I have notes on my slides. So this is the Milky Way. It's our home. And there could be as many as 40 billion planets in here that you know about this. And so far, we've found about 20 that might be livable, habitable planets. And they are from 4 to 1,200 light years away. And that's the same as 24 trillion miles. So if we think about that and really how precious this one is, that's right here. I'd just like to start our talk with that reminder. Next slide. Because we know about this one, it is habitable. It's habitable right now. And it's incredible, unique. It just fits the mold. It's the right everything, kind of like Goldilocks, that allows life to get started, evolving, and develop into this incredible complexity in terms of human life and every species that we have today. Next slide. And what a place it is, huh? Look at these beautiful life forms that we have in front of us and around us, and we know how complex they are, from each cell to each forest. Astonishing. Next slide. It's filled with abundance. It's filled with possibility. It's filled with opportunity for human health and thriving, and also ways to live equitably and sustainably on the planet. We can imagine this. We can see this. We know this happens, so we know it's real and possible. So keep that image in mind. So planetary health is this concept, and put simply, it is the health of human civilization and the state of the natural systems on which it depends. I think this is important for health professionals to have in mind, because oftentimes health professionals' perspective ends where the patient ends, or ends where the family ends, or where the community ends. And where we are in history, in human history and planetary history, we need to also be aware of these large-scale impacts that are changing our opportunities for health and thriving today. Next slide. And I think in terms of healthcare, there's a lot of factors and features of planetary health, and I invite you all to look that up. There's lots and lots of papers. Planetary Health Institute. Check out the Resiliency Center in Sweden. But I pull out these three features, and a couple of little advances, you guys, get to these next few little things. And I pulled these three out: climate change, which we're talking about today; biodiversity loss, which is its own problem. If we didn't have a climate problem, we'd have a significant environmental crisis from our biodiversity loss, and also resource depletion. And I pulled that one out because healthcare is so wasteful. Next slide. So this is a slide that just reminds us of how global warming is happening. And so this is from the Truth in 10 slide deck from the Climate Reality Project. And I invite you to take that if you haven't. So this is the basic science of global warming, which has been understood for a century. Energy from the sun comes into our atmosphere in the form of light. It's absorbed by the earth. Some of that energy is re-radiated, and it would normally go out to space, some of it. But more and more, as we are adding heat-trapping pollutants into our atmosphere, it's getting trapped in that layer. So that means it's a global issue, and you look at average increase in temperature, but those averages vary across the surface of the planet. But it comes back to these greenhouse gases. That's what's driving the issue. Next slide. And greenhouse gases can come from a number of sources, and these are some. Most of them have to do with fossil fuels, not all. For instance, thawing permafrost. But most of the others do come from fossil fuels, and that really is the biggest problem that we need to address. Many of these have overlaps with healthcare, and I'll talk about that as we talk through today. Next slide. All right, well, a little bit about health and healthcare. And then we're going to do another slide, because I got another option for the future here, another possibility. But unfortunately, this is not the future. This is slightly, oh, another slide. And another slide, that one, thank you. These are images from today. And these are, again, are reflective of what Dr. Patel said. We have incredible air pollution in many of our cities. We have novel entities. These are the chemicals that we are being exposed to more and more. This is an issue in healthcare because largely from the plastics, not only the plastics are a growing problem. You all know that they've been found in soil, air, and water, also blood, and now breast milk. And some of them are hormone disrupting or endocrine disrupting chemicals. This is another health crisis that we will be seeing more of in future years. Wildfires, especially here in the West, heat-related illness, asthma, all of the things that Dr. Patel talked about are happening now. Next slide. For instance, in our area, in the cities that I work in across the Northwest and California, we've seen many examples of smoke and fire. You all live with this. I'm not sure where everybody lives in Montana, but certainly in Western Montana, we have smoke that fills our valley sometimes for a couple of months. And so that's really tough to live with over time. We've seen images, for instance, Spokane, Washington, and Portland, Oregon, both had the honor in the last few years of being the most polluted city in the world during our smoke days. So we know that that is a health problem, as you just heard earlier. Right? They also don't hit us equitably. So Dr. Patel used this slide. And we take this seriously in Providence because our mission statement is service to all, especially the poor and vulnerable. And the vulnerable are really these people and these individuals in these communities and these neighborhoods that Dr. Patel identified. And I'll talk a little bit more of that when I talk about our environmental justice work. But we hold this front and center. And in fact, all of our work being anchored to justice is important because it impacts people today inequitably, it impacts future generations inequitably, and it impacts other species inequitably. So all of that is part of why this makes sense within our mission-driven everyday commitment to the justice issue. Next slide, or this one, this slide. So healthcare is part of the problem. Healthcare in the US generates about 8.5% of emissions every year, national emissions. Healthcare worldwide emits 4.5% of global emissions, and US healthcare is a quarter of that. So we are very much outpacing our neighbors across the world in terms of the pollution that comes from our own healthcare. And that is just not what we want to do, is it? Because we're here to protect health. These clouds, I'm not sure if you can read that, are some of the issues that we address, and I'm going to walk through most of these in detail, so I'm not going to read this slide to you. Next slide. But this is the issue, really. People come to us when they need help with their disease or illness or difficulty. They access health services. That's great. We want to be there. We want to deliver the best care we can. But we're actually causing healthcare pollution at the same time. And that's not what we want to do, because that can further drive disease and illness. So one more little click will bring up a lightning bolt, which shows you that that's where I work. It's to disrupt the pollution out of healthcare, so we can kind of bring it back down to something that's not causing harm in this way. Next slide. This one gives you some ideas of some of the things that we can do. Again, my talk today is mostly about solutions, so I'm going to spend a lot of time on some of these, but this gives you an idea of what we can do, from focusing on our energy procurement, diverting waste, reducing emissions from chemicals, talking about climate risk in our emergency preparedness plans, better food, better transportation, and education for all of us, like a day like this. Next slide. Because really the choice is ours. And I say that about us in this room, yes, about us as health professionals, yes, and really about every adult alive today. This is what we've landed in. This is when we're born. Not our fault. We can't solve it alone. But who else is going to solve this or help it if it's not the people who have agency today? And that, I think, is all adults. All adults who can. And most adults can do something. All of us can do something. So I like to have these two ideas. And this reflects also something that I said about there really is a possible future. I sometimes say that I'm rationally optimistic. I see enough good stuff that's happening, solutions that are out there, that I think, we can get out of this. I have no doubt about that, actually. I'm not sure that we will every day. Depends a little bit on my attitude or my mood. But I know that when we call ourselves and each other to respond and act, we have a lot better chance than if we do nothing. All right, next slide. Okay, this is a little bit of an experiment. It's to get us thinking just a little. And these are going to have a lot of clicks. So just one click first. So do you guys know what this is? And from that perspective, could we have imagined one like that? What we live with every day. I mean, we don't see that at all. Just imagine what that change was, and try and think back to, I think the first iPhone was 05 or so, 2005, maybe 2004. Think back to 2003, before you'd ever heard of that. And just imagine, you can't imagine it, right? Because we weren't the inventors. I want us to get in the mindset of when we're stuck in a problem, we know that there will be a solution, but we can't imagine what it is yet. How might we expand our thinking? That's what this little spell is for. Okay, next one. I have a few of these. This is today, isn't it? So we are really dependent on our fossil fuel vehicles. We're creating all this air pollution. We've often said if we just stopped driving our cars, that's going to help our air pollution problem quite a bit. But we're not there yet. However, one more click. This is coming fast, partly because of the IRA, the Inflation Reduction Act, which is really starting to fund electric vehicles, charging stations, more funding for creators. This will happen, I predict, very quickly. On a large scale. That doesn't mean that every one of you are going to buy an EV in the next year, but I think within the decade, we're going to see enormous, we're already seeing it. And that makes a big difference for health. But 5 years ago, would anyone have thought that it would happen like this? Okay, go to another one. Again, we're dependent on fossil fuels today, mostly for our energy. Lots and lots of new ideas, new technologies, new ways of thinking about this. And we're seeing it all the time. And we have the solutions. So one more click. We have renewables, we have hydrogen on the horizon, we have micronuclear. And so we know that we can make this transition, but it's not going to be easy. So I encourage us all to keep pushing on that. That's one of the best health things we can do, is get off fossil fuels. Okay, let's go to another one. So this one is true. And I hate to date myself quite so much, but when I was a nursing student, patients could smoke in their rooms. Today, we had to tell them as nurses, I had to tell them, remind people to take off your oxygen so they can how many patients burn themselves? Quite a few. We just scared, oh, God, we can burn. Yeah. Now, when we're quick, we just can't imagine it, right? So it was a long time ago now, at least a decade, that we moved to smoke free. But that was a hard fought battle that took decades. So it's no surprise that when we're up against trying to change off of a fossil fuel economy, propaganda, enormous dollars, billions of dollars, trillions of dollars, no surprise it's going to be an uphill battle, and it already is, but that doesn't mean we shouldn't do it. Obviously, we must. Okay, another one. Also, I hate to admit this, but truly, there was a time when we thought in healthcare that, well, when patients come to the hospital, they're kind of ill. They're more likely to get an infection. How do you like that? We accepted that people, when they had cancer, when they were immunocompromised, when something else was happening, well, they're likely to get an infection, more likely to get an infection. So, one more click. That has changed a lot. We don't tolerate that. We treat every infection like a crime scene. You know, we have people who are jumping in and making changes and understanding and unpacking what happened. Great work. All right, we keep going. Enormous problem. This is the plastics problem. And I struggle with this one. It's really hard. We've got all these single-use plastics. It's disposable items, made of stuff with hormone disrupting chemicals all over. The stuff that comes out of hospitals is astonishing, and it's a lot more plastic than to a general household, obviously. What's our solution? What are we going to see? One more click. I don't know. These are questions. We're at this point in time where we're in between this situation that's not tenable and a solution that's throughout our economy. There's things developing that are plastic free, that are based on bioplastics or other
Recording in progress.
and also efforts to continue to work on recycling, etc. A lot of limitations there, a lot of innovation needs to happen here, and we encourage anybody who wants to dive into that. This is the place where we need help in the world, not just in healthcare. All right, the next one. And these are headlines from the last few years. And so this is depressing to me. I don't like to read these headlines. U.S. healthcare system is top greenhouse gas emitter. Is healthcare pollution making still? That's been really my life's work. It still is my life's work. This is happening today. One more. But we know that that's not necessary. We already know how we can do this differently. Not easy to change healthcare writ large. We know that, especially after a pandemic, during the financial crisis. We know that building a new hospital is about $1 billion usually. We're not just going to go build new hospitals or replace all our boilers or all the things that would be necessary to get to a point like this. But the point I want to make is we know how to do this. This future is not so far. Okay, one more. So in the 90s and early 2000s, some of you will remember the seminal work that came out of Crossing the Quality Divide from IHI, Institute for Healthcare Improvement, and AHRQ. And they really saw what was happening in U.S. healthcare in terms of the unintended consequences. So healthcare acquired conditions. This is a short list. There's a longer list of these that were kind of just not taken so seriously. It was kind of like, people are going to get infected. Now, that's not how we do it. Yeah, people have these other things too. It's just, it's so busy in healthcare, we can't prevent all those things. Not the case, much more focus on this, including the unexpected deaths. But you see, on the other side, there's this black screen. That's a black screen because there's a half of this effort that we're not paying attention to. So if you click it, and that's the harm from healthcare generated pollution. We already know about this. And we know from a study in 2016 by Ackerman and Sherman that the harm from healthcare generated pollution is of the same order of magnitude as all the other healthcare acquired harm. So in other words, we're ignoring half of it. Where we are today, we really are. Things are happening, but we are really still ignoring half of it. Some of that harm is from the chemicals we use. Some of it is from excessive water use, excessive resource consumption. But the one that I want to focus on today is the harm from climate change, from our greenhouse gases. So another study out of Columbia University, Breslin down there, quantified that if we were to look at greenhouse gas emissions and morbidity, 4,434 metric tons of carbon dioxide equivalent, I'm going to talk a little bit more about that, is associated with one premature death. Now you look at that other number, 442. I'm embarrassed to say this. I have this number on my bulletin board because that is the equivalent of the premature deaths caused by Providence's greenhouse gas emissions in 1 year.
Yeah.
I will also say we probably have fewer greenhouse gas emissions than a lot of health systems and hospitals. That is just for the climate emitted carbon emissions. So this is not what people know about or think about in healthcare. I'll tell you, this is new news to most people in healthcare, even our healthcare team. But this is what motivates me. It is the same issue that we were up against in the 1990s of unintended harm. This is our unintended harm from healthcare itself today, as well as all the stuff that we can do that Dr. Patel was talking about and that we can work on with justice and with better food and with helping your communities. But also we got to clean up our own act. So that's what I'm going to talk about, okay? All right, let's keep going. Now I'm going to talk about some solutions. And same as before, please interrupt me if you want to ask questions or whatever. And we're also going to have a little breakout session after this to talk about some of this. But I'll keep going and I talk kind of fast. So Providence is a large health system. These are some numbers from, if you one more slide, some numbers of what we are made of. 52 hospitals, over 1,000 clinics, 120,000 caregivers, which is another word for employees, 36,000 nurses, etc. We also have a high school, a University of Providence in Great Falls, that's a Providence, part of the Providence health system, a number of spin-off companies, etc. $25 billion company, meaning $25 billion in revenue every year. Next slide. And we're in these 7 states. So I used to work at a Providence facility in Missoula. And so you may have heard of that, St. Patrick Hospital. We also have a Providence facility in Folsom, Montana. So those are both in the western part of the state, and that's it in Montana. So I will say that St. Patrick is the oldest of all these hospitals, the 52 hospitals in the system, on the same ground, which I consider sacred space. I'd love to be on that block and know all the things that happened over the past 150 years right there. So most of our hospitals are in Washington and California, with Oregon coming next. So much of my attention is really on the West Coast and with their governments, etc. Next slide. So in 2020, we announced our goal to do as much as we can about this by 2030, because the scientists were telling us that this is a pivotal decade to try and turn this enormous ship around so that we can stave off the very worst. So we set that goal. Our president here, Dr. Hoffman, has been out talking about it all over the world. Our leadership does. We have a major program going, and I'm going to discuss that with you today. But it's daunting, to say the least. Next slide, or this slide. This is just an overview, and don't worry about this too much, but I'll give you an idea of the breadth of what we're trying to do. So I call this a visual strategic map. And it gives you an idea. On the top left is our mitigation work. And I'm going to tell you about the WEACT framework. And that's where we're really dialing down every kilogram that we can of CO2. The top middle is our adaptation work. And these all overlap. So it's not so clean. But this is work that we're doing, especially in response to the HHS pledge that Dr. Patel mentioned, to develop our climate resiliency plan this year. And I'm going to tell you about that. The next one is advocacy. So we think of those together, mitigation, adaptation, advocacy as anchors to what we're doing. Others have different schemes, but these are kind of the basics, like Helen might call it mitigation, resiliency, and leadership. So in advocacy, we do a lot. I report up now through the Government Affairs Division. That means the people who do the lobbying in all these states, plus the feds. Also, we work with many other agencies, and I mentioned a few of those, IHI and AHRQ that we're working with. We ask clinicians, not just clinicians, all caregivers to volunteer, and we have a whole way of setting up volunteer activities that are environmentally related. We ask people to speak. We ask people to use their clinician's voice to protect health in all ways, and now to add climate health. It's great that the organization supports that. Our vision is health for a better world, and there's just not a way to not include climate risk in that vision for the future. The bottom right are a bunch of different internal groups that we have. The bottom left are key supportive elements that really would go with any initiative that you might have. But we pull this out because people say, well, yeah, but what are you doing about X? And what are you doing about Y? I say, okay, here's how it fits together. We have different aspects going on in different parts of the organization. It's very hard to keep up with everything that's going on. All right, next slide. So this talk is called decarbonizing. Decarbonizing is a buzzword right now. I would say there's buzzwords that come and go. Sustainability is kind of another one that comes and goes. So decarbonizing is a buzzword right now. The National Academy of Medicine has a collaborative on decarbonizing healthcare. We're part of that and serve on several different committees. Several of us do. So what does it mean? So Dr. Patel talked a little bit about this, but there are several types of greenhouse gases. These are 4 of the most common: carbon dioxide, methane, nitrous oxide, fluorinated acid. All of these are aspects of healthcare pollution. For ease of discussion, those are of different strengths, different global warming potentials. So what we do is we calculate them as if they were CO2. So that little e is CO2 equivalent. So we translate the gases so that it's all in the same measure, and that's carbon dioxide equivalent. MT stands for metric ton. So if you start to see MT CO2e, that's what that is. We use it a lot. We sometimes use kilograms of CO2e, but that's what we're talking about. So to decarbonize is to reduce all of those greenhouse gases. Carbon is a euphemism for greenhouse gas. It's confusing because people who come from chemistry say, well, everything's carbon-based. That's true, but right now we're talking about carbon as greenhouse gas. Next slide. So we developed the WEACT framework because these are in our mitigation work. I believe that this is where you'll find most of the work to be done in one of these categories. So that's waste, energy and water, agriculture and food, chemical, transportation. One of the things that we know from studies, including the use of CHAMP, which I'm going to talk about later, that's the climate and health tool for health professionals. We know that the main reason health professionals don't act on climate, they're overwhelmed. The second main reason is they don't think they know enough. I would say that all of you today, after these first 2 lectures, you know enough. You know enough. Talk about this, you raise the question, you say, what should we do about these? Should we be concerned about the stability of these pharmaceuticals? You know enough to ask the questions and bring the conversation forward. But the overwhelmed part is a little bit different, isn't it? One aspect of overwhelmed is the intense emotional response we have to this. Another is it's confusing. It's so much stuff. We're trying to talk about changing the world. We're talking about changing the entire economy when we talk about environmental stewardship. So how do we think about that? I like to bucket. I'm a bucketer. Put things together, make them smaller, make it easier. So the WEACT framework does that. And also it reminds us that it's we, not just me, it's we. And it's not just thinking about it, and it's not just caring about it, because those are important. We also need to act, which you all are doing by coming out today, so we appreciate that. Okay, next slide. So I'm going to walk through the WEACT elements, waste being first. Healthcare waste is enormously complex, and it's also enormous. Last year, 2020, well, actually 2021 is our most full, complete year of data. We'll have 2022 in a few weeks. 92 million pounds, 92 million pounds. Hard number to imagine. That's just us. 92 million pounds. So we have about 30 different waste streams that we think about and talk about. Many of them are regulated, hard to manage. So we've set a goal, and it's this one, to divert more than half of our waste from landfill and or hazardous streams by 2030. We think it's important to include hazardous streams because we create a fair amount of hazardous waste. We're talking about disposed waste, the stuff that's really going somewhere to be treated as those categories, landfill, biohazardous, hazardous. Talk about diverted waste, that's waste that would have gone to the landfill, but we're pulling it out to get it to composted, recycled. Universal waste is a subset of hazardous that can be recycled or donations. But the most important is the avoided waste. And that's the waste we don't create. And in some ways, first of all, as I said to others here, recycling and waste is like the gateway drug here. So it's a great way to get people involved because they start to come in, they're frustrated by all this waste that goes through their fingers. There's so much of it. And yet that leads us to learn more about, okay, well, what are the carbon emissions of that? What does it mean about environmental justice? What does it mean about chemical exposures? So I think what I like about this scheme is that it really gets us down to that avoided waste piece. And we're asking people to measure it. So how do you measure waste that isn't there? Well, we can do it partly by estimations and partly through actual knowledge. For instance, we use reusable sharps containers. You all, if you're in hospitals, you will have seen that. You have these blue bins that are on walls where you put sharps and stuff, and they can be used 600 times. They get removed, dumped, cleaned, remounted. That means 599 of those were avoided waste. So we count that in every hospital. Reusable isolation gowns, reusable dishware, reprocessed items, which is another waste stream. There are a number of things that are starting to be developed. They're more back to that slide on plastics I mentioned about the circular economy. So how do we keep that going? Because we pay a fortune for this, 15 million, what we paid for that 92 million. So waste gets a lot of attention, partly because it's what everybody asks about to start. So we figured we better have a good response. The E is for energy and water, very complex. We spend about $120 million a year on energy. We have 40 million square feet. We think that we can be 100% renewable electricity by 2030. Natural gas is a problem though. So, next slide, sorry. So, we work a lot on our energy through two primary ways. One is all the efficiency work, and that's what everybody can do in any building, anywhere, including your homes. And the second is through procurement. That's very complex. The electricity market is complex. Offsets, not offsets, but RECs, and planning in the far future is complex. So that we have help for with the consultant, and that we use Schneider Electric to help us work through much of that. But we're well on our way. As you can see, 26 of our facilities are already on renewable electricity. We're in Washington and Oregon primarily. And we continue to push as much as we can for all that plus efficiency. Water is a big issue for us because we're in the West and we're in these Western states, and we know about California drought, but also much of Oregon is in drought. You wouldn't know that. Thinking it's a wet state, it's really not. Good half of Washington's in drought. Montana's often in drought. And so we have really doubled down on our push for better efficiency for the most part. Sometimes it's as simple as finding leaks. It's just amazing. You know, you might do that in your own house as well. You didn't know that was leaking. So we've developed quite a good system for data tracking, which gives us alerts about when something has an unexpectedly high use. That's one way to do it. We also consult with consultants who come in and do audits, because detailed audits let you solve the problems. So that's part of our strategy for both energy and water. Next slide. Agriculture and food is also a really big deal. You know, I say waste is a gateway drug, kind of so is food. Everybody cares about food. We all like to eat, or we eat frequently. People have strong opinions about food. People want food to be a certain way. And we do too. We want it to be healthy. We want it to be chemical free, and we want it to be low carbon. So we have goals, and we work with another third-party vendor who services the cafeterias at 41 of our 52 hospitals. And so we've got goals with them, and they're these: to decrease the carbon intensity of meals. We do this by tracking that based on our purchases. And we use their product called the Carbon Blueprint, and Healthcare Without Harm product called the Cool Food Pledge, which in the end gives us data about the CO2 emissions per meal. So we're watching that go down over time. It's not going to be to zero, but there's a lot we can do by better portion control, buying less beef. Beef is really kind of the driver behind all this. Some of the other meats and dairy are too, but beef honestly is the one. And we know that now because we've been able to see that data from our own millions of dollars of food because of waste. Another big issue. In the US, 30 to 40% of food is wasted. In healthcare, 8 to 12%, 10% of garbage is food waste. Crazy. That goes straight to methane. Not good. So we work on that on both the prep side. We have equipment and computerized ways of measuring how much food waste. Like I think about this at home a lot. When I'm chopping a carrot, how much of that end did I actually waste? That goes into our metrics. How much of the meat were we able to not throw away? And so each hospital looks at that. They have cameras. It's kind of freaky. They have cameras over the food prep site because that's the way we can train people to be more efficient. And then on the post-consumer side, we're composting wherever we can. That's very important. We have to have industrial strength composting. Many of our Montana states don't have that. Missoula does. We've done amazing work to get food out of the waste stream. And then we work on packaging, which is difficult. And that went downhill during COVID. It really did. We backslid with the amount of plastics we used because we felt like we had to wrap every banana with things like this. Kind of crazy. So we're kind of coming out of that, getting back to using more reusable dishware, avoiding styrofoam, certainly, etc. Let's keep moving. Next slide. The C is really important in healthcare for a lot of reasons. One, if we start over on the far side, the right side, chemicals of concern. This has been the focus of groups like Healthcare.Harm for many years. And we know that clinicians are heavily exposed to chemicals of concern in the workplace. Thinking about all the exposures to plastic, antibiotics, chemotherapeutic agents, finishings and furnishes of materials, cleaning chemicals, etc. So it's just true. And that has been studied by body burden studies in physicians and nurses in healthcare. So that's been a focus for a long time. What's been a focus more recently is the greenhouse gas impacts of chemicals that we use in healthcare. So these few that are listed here are good examples. Anesthetic agents, and you've probably heard about this. There are 3 common volatile anesthetics. One of them is enormously polluting, and it's also enormously expensive, which is really good for people like me. Because if we can drive down carbon and drive down costs, that's a lot easier. So making good progress with that through the leadership of our medical director, Dr. Brian Cheesebro, who's an anesthesiologist. Secondly, nitrous oxide. Nitrous oxide is also an agent used for anesthesia, sometimes, a lot less than the general anesthetics. And it is typically piped through the walls with the medical gas. So you have a port, you plug in a doohickey, and out comes the nitrous oxide. Turns out, and we've learned this after frustratingly trying to lower our purchases in a few sites. We've learned that it notoriously leaks almost everywhere if it's in a pipe system. It's kind of built into the walls, and then you can't really tell what's happening. You can assess the valves themselves, but really not. So the reason we know is because we compare what we purchased to what was clinically used. And we've been showing that 5 to 15% of what we purchase is clinically used, meaning 85 to 95% of it is going into the atmosphere. So we're just working on this one and we're making good progress, but this is challenging work because it's a lot of behavior change. You know, when we have to involve humans in all this, it gets kind of complicated. Another is the inhalers and the propellants from those. And I'm not going to go into great detail because I'm not an expert on that. But again, Dr. Cheesebro and our pharmacy colleagues, shout out to Dr. Blackburn on the airwaves, have really dived into understanding the different medication mixtures and available dosing of inhalers. And there's a lot. Dr. Cheesebro reports that we have about 200 on the formulary. Some of them are with very high global warming potential propellants, the thing that makes it the medication come out. Some are lower on that list. Some have no propellants, dry powder inhalers. But it's a complicated story we're finding, and there are clinical decisions to be made about the most appropriate drug and drug delivery. And now we want to add to that complexity the global warming potential of that choice. So this is part of the clinical education that we're getting after, and that I hope you can help us with. Okay, next slide. Transportation. This is, as on Dr. Patel's slide, transportation really surpassed buildings, and as of 2018, is the biggest sectoral contributor to climate change. That's why we're really excited about the transition to electric vehicles. We understand that they won't be carbon-free until the grid is carbon-free, so that we can charge in a carbon-free way. So we're working on this in a lot of different categories. Business travel, flying, that sort of thing. Employee commuting, that's by far the biggest. We have almost 100,000 metric tons there. Care delivery, that's when people go out to hospice and home care and others And then they get reimbursed for their miles. That's a really big one for us too. And then supply chain deliveries too. We're working on all of those really hard. Like the electricity grid, that we're dependent on changing our entire marketplace really and society. Same with transportation. So some of that is out of our control, but we're doing what we can. And we want people, the people who are, you know, the vendors for this to know that we're doing that. So we talk about it a lot. Next slide. So I hope you can tell that what I've said so far is very data driven. So we've been able to construct over the past 2.5 years or so, a really remarkable database. And this gives us, for the 52 hospitals right now, but we're adding another 500 buildings here by the end of Q2. So right now we have for every hospital, any resource that we're able to track, like electricity, water, all those waste streams I mentioned, nitrous oxide and the anesthetic agents, all the business travel, et cetera. We know how much a hospital used, we know what it cost, and we know the carbon emissions for that. So every month we really have a report that can help drive efficiency and also let us know where we are with our carbon goals. So you can't read these images, but I just can't tell you how important this is. I think of it as the backbone for our work for a few reasons. One, how do we know we're making progress if we're not measuring it? Two, healthcare people are very data driven. And three, when you use averages, like from somewhere else, I'll tell you more often than not, I say, well, we're not that good. Okay, well, let's look at how it's going here. Look at this hospital. Really powerful. Next slide. We also have our environmentally preferred purchasing policy. So we use the greenhouse gas protocol, international greenhouse gas protocol, as just about everybody does, to track our carbon footprint, our carbon emissions. And in that, yes.
Can you get a little closer to the mic?
Thank you.
Thanks.
And in that, there's scope 1, scope 2, scope 3. I'm not going to go into that today, but scope 3 are indirect emissions from basically our value chain, they call it. The first two categories are purchased goods and services and capital purchases. Those two categories are half of our carbon emissions. So what we purchase is really important. And it's really hard to change because that too is something that the whole society needs to change about. We don't have transparency into what we're purchasing. Companies aren't required to report. It's voluntary amongst those who are interested. And then they're only reporting scopes 1 and 2. So it's really hard to know what we're doing, what even things are made of, and what chemicals are in it. It's part of, you know, it's an American thing more than it is a European thing, and it's considered proprietary information a lot. So we suffer from that lack of transparency. We really do. But because we know it's so important, we're really working on this. This is hard. This is the hardest work that we do, the hardest to make progress. So we've developed a policy. The policy can help us a little bit, but it requires every single person who makes a purchasing decision, which is almost everybody at some point, to be aware of the environmental impacts of that decision. So we spend a lot of time going and finding that so that we can provide that information so people can make better choices. They still have to worry about the cost and the quality and the availability and the user preference and all the regulatory stuff. But we also want them to consider environmental impacts so we can help transform the culture and therefore the results. All right, next one. But it comes down to something like this. Okay, who wants to change? Oh, we all do. Okay, who wants to change? We all, this is an experience I've had many times. And it's just, you've got to know that when we go into it. So if we can do it with a smile, do it with a little bit of incentive and encouragement, that can help. If we can make it easier. One of our visions, or not our vision, let's see, our promise statement in Providence is know me, care for me, ease my way. And so we say that a lot. I'm going to ease your way with this. Next slide. Got another one of these. This too kind of happens, doesn't it? Let's set the big goal and then let's just hope it works. Okay. So that's not how it works out. And as mentioned, we're data driven and evidence based, and we keep that in front of people. Okay. Next slide. If we think back to my visual strategic map, this was in the top middle. So when the HHS, Department of Health and Human Services, put up their pledge last April of 2021, it was that hospitals and health systems would commit to a few things. One is to reduce scope 1 and 2 emissions by half by 2030. That's not easy. We've been working on it for a while. It's not easy. To get to carbon net zero or carbon neutral or something like that, yet to be determined by 2050. I'm telling you, that's not gonna be so easy. Really not. And the third thing is to have a climate resiliency plan by the end of 2023. Okay, that we can do because it's a plan. Doesn't mean we've solved all the problem. But I'll tell you, when you start to think about climate resiliency, and this is definitely a part of our decarbonization strategy and our entire environmental stewardship strategy, it's complicated. So Dr. Patel talked about that heat wave in Portland in 2021. It snuck up on us. We didn't think it was going to be that bad. The scientists didn't think it was going to be that bad right now. We know at some point before long, but it already happened. And that's just one out of many, and it can get hotter. So our buildings were built for temperate northwestern climates. And that's the requirement. You have to build something suitable to your climate. They were not built for 160 degrees. One of our biggest hospitals in Portland, St. Vincent Medical Center, experienced on a big, broad south face, the door jambs and window frames worked. It's like the building was melting. Now, I just have to tell you, we have 40 million square feet. This is truly a daunting problem. Because this has already happened and it's going to happen again. We can't rebuild those buildings. We can't, as I said, replace every system that we have. So then we start to think about adaptation of our building. In that case, when the temperatures were so hot outside, the building temperature also got very hot, obviously. The steel that it's made of, the concrete that it's made of, held on to heat. So it was difficult to manage the HVAC systems and the humidification systems for about 10 days on getting cycle list. So that's an example of an operational response to our climate resiliency planning needs. Another hospital I just learned about last fall in the Seattle area, because of the wildfire smoke and ash, the ash was getting into the water coolers. So that's a system that they use water to help cool the buildings, and it's exposed outside. It's not drinking water, but it was polluted enough that they had to flush the whole system and use some chemicals to clean it. So that was a problem on the environmental stewardship side, the resource use side. And so they now have a plan so that they can keep that from happening. Thank you. But the issue is these things are happening now. So how do we respond to them? How do we anticipate them when we don't fully know? Another section here is clinical. So we've been talking about this morning with Dr. Patel's talk and some of your questions. What do clinicians need to know? How do they think about heat? What can we provide for them? What do our pharmacists need to know about stability of medications? What do our community health workers need to know? Not just heat, but smoke in our parts of the world. So this is about education. It's about education for clinicians because not everybody that I work with is interested in this like you are. But we need them to do this. It's just as important as infection prevention now. That important. So we're working on that. Also, what about if the caregivers live in the same towns that are experiencing these things? What do we do about their needs? Can they get to work? Can they work? I'm still shocked by a story I heard from some of our home care nurses in Northern California. They have taken on to carrying chainsaws in their cars when they go on visits. This is because of fires and downed trees, and they just don't know. Isn't that astonishing? We would have not thought that 20 years ago, that home health centers need chainsaws. So clinical knowledge is a big thing. And then the third circle here is about community. We have worked always, Providence has, on our community strengths. And so largely on social determinants of health, poverty, homelessness, education, food security. Now we're asking our community-facing teams to consider the environmental determinants of health. And we've been able to do a scan from Anchorage, Alaska to Lubbock, Texas to understand what are the issues in these communities and who's impacted. So some of it's climate, but some of it's proximity to highways or industry or the other events that people live with, because that's the justice issue. And we need to help make sure, one, we're not worsening the problem, and two, help where we can. We can't solve those problems, but hospitals and health systems are typically anchor institutions that really impact the communities and vice versa. I want to call out mental health here, and I know that we're going to talk about mental health today, but this is another piece of resilience that we work on. We work on it internally, and we work on it, we will be, I hope, more working on it externally, because this is it is an issue that is affecting our caregivers. We know that. I know that in part anecdotally. You know how hard it was in the pandemic in healthcare, in acute care, and everywhere. People were crushed. I mean, it was just utterly exhausting, and it nearly broke health seriously. And even so, I had people come to me, find me, I didn't know them, they would email, it's like, I'm so glad we're doing this. That's because this is causing a lot of angst and fear and difficulty. I'm glad we're doing it too, but boy, this is challenging, it's challenging, isn't it? Even so, we're finding solutions. Okay, I gotta keep going. Thank you. Next slide, please. We are addressing our clinicians more, and this is something that we're really been able to work on this year because of the pandemic. We just couldn't get in with people so much. We're still working on clinical issues and the ones I told you about and others. But if I think about the 120,000 caregivers, about 90,000 of them are clinicians, they're healthcare professionals, like many of you here. They're the people who know how it works. They have the answers in terms of changing operations and changing behaviors. But my experience is they're often left out of any discussions about environmental stewardship because they're thought to be too busy, or they don't know enough about solar panels or whatever. But we have got to bridge that gap. I have often been the only clinical person in these conversations, but that's not the case these days. So we want to tap their wisdom and also help them understand. I'm going to skip over this because I'm out of time. I can talk to you later. But these are the things that we're working on in 2023. Environmental stewardship and literacy. So just what we've talked about today, if we ask most of our clinicians, they wouldn't know what MTCO2 means. So we want to just help build that language. Thank you. Help build that language so that they can make good decisions that are informed, especially practice decisions. The waste optimization strategy I told you about, we really want to focus on the clinical spaces, partly because that's where virtually all the waste comes from. Surgical supply optimization. This is a wonderful tool that a process improvement expert of ours in Oregon built. And they are able to look into OR kits. If you know surgery, there are kits that have all the supplies and a whole lot of redundancy, extra supplies, duplicates, triplicates. We might need this, let's put it in there. And then very often they throw that out. Yeah, next slide, sorry. And then very often, if it's not used, it's discarded. So they have a process where they pull data out of EPIC, our EHR, electronic health record, to see what was really used, and then work with the surgeon to change what they want in those kits. So this has gone live at 2 hospitals. Just want to say that at those 2 hospitals, the savings alone are $2.8 million a year. That tells me we're throwing away probably $2 million or so, because there's some processing costs of supplies, brand new supplies. When people say healthcare is wasteful, I say, I got an example for you. So we're working on it. And of course, keeping going with our anesthesia and our nitrous oxide and our inhalers. Okay, more, go to the next one, please. This is hard to do. And communications, we feel like we need to talk with everybody in a variety of ways. And so we do it as much as we can through our SharePoint, our emails, our social media, our events, etc. Using the WEAC framework as kind of the backbone, we have toolkits, etc. Couple more slides. And I know I'm eating into question time. Haven't talked a lot about the value proposition, and this would be its own lecture. It really would. But I just want to point out what I hope is obvious right now. This helps work toward efficiency, not just in environmental issues, but across all of the operations. Safety, think about the chemicals. Caregiver engagement, amazing, really important, especially in our part of the country on the West Coast. Recruitment, we've already been contacted a number of times by leaders who say, hey, so-and-so, I interviewed so-and-so, and they asked me, what are you doing about the environment? And I couldn't tell them. Well, let me tell you. So we're trying to get that word out more, of course. Innovation, coming up with solutions, and these are real. Mission alignment, important for us, of course, and reduction of harm, like the whole thing I talked to you about the 442 that I keep on my bulletin board. These are all of value. And I want to point out that there's not a mention of money right there in this value proposition. But I can tell you that we're already saving $11 million a year. And we believe by the end of the decade, 2030, we'll be saving about $100 million a year. I also want to say that before the pandemic, our margins for the whole health system were $15 to $20 million a year. So this matters because this is like below the line. It's the cost of doing business stuff. Another piece. Okay. Anyway, one more slide. We're on the right track. We've reduced carbon emissions by 13%. Several of our hospitals are already at our waste goal. 26 actually facilities are already on 100% renewable electricity. I've told you about some of the money, and we have this database. So these are some of the things that we're happy about and working toward. One more slide. And we were asked by the Sisters of Providence who handed over this work to lay people to be good models of stewardship. So we take that seriously and we're involved very much, and not just me, but about a dozen of us who are involved all over the nation and even the world to talk about this, to help guide decisions, to help add input and examples, and now to back it up with data. Very powerful, because otherwise people are kind of guessing. And so these are just a list of some of those that we do. One more slide, because it reminds us again that this choice is ours. And it's not to put a burden on you in this room, but it's a reminder that the pressure that we feel is also the solution that we have. That's the way I see it. I tend to be an action-oriented person, so I'm empowered by a statement like that rather than overwhelmed by it. If you're overwhelmed by it, phrase it differently in a way that works for you. But the general idea is, it's a big issue, and we're moving in the right direction, especially people like you who are paying attention, and we need to keep doing that. Thank you very much. Can you tell me what we need to do?
We have about 5 minutes for questions.
Okay. That's right.
So I think equally bad, to fire season is the every other year legislative season.
Okay.
And I wonder if Providence does lobby here in Montana, and do they just stay in like a healthcare lane, or is there actually efforts made in energy and environment and things like that?
So the question was about Montana legislature being challenging and every other year, and what does Providence do about that specifically in Montana? So I mentioned I work in the government affairs division, so I know all the lobbyists. We have government affairs professionals who work and plan on strategy, work with the different states all year long, and also attend as much of legislation around our 7 states as they can, including Montana. In Montana, we use a contract lobbyist, but the contract lobbyist follows what the Providence strategy is, and it does include climate safe policy. And that doesn't always mean that they're going to be on the bleeding edge with environmental groups. But it means when they have an opportunity to remind about, oh, this is important because air quality is such a driver of poor health outcomes, they do. So I would have to look, and find out some examples for you. But I will also say that in Montana, they're working hard to maintain Medicaid funding and Medicare funding, and those things that are at risk as well. And those are equally important, clearly, because those really impact people negatively as well. But I've been really impressed. I've been happy to learn about the work and the boldness that Providence does. And I can find out more about Montana for sure. Yeah.
Thanks, Beth. That was wonderful. There's a frustrating thing that I have found when I was working with the plastics that we use and the single-use idea. And there's always a fight. I mean, when purchasing new equipment, we even go through more and more single-use stuff as opposed to less and less single-use stuff because of the infectious disease issue. So how have you guys, or how are you addressing it?
Yeah. So the question was about, I was tending to use more and more single-use plastic disposable items over time. I have absolutely seen that in my career. I mean, 30 years ago when I started recycling, they were an issue, but it's nothing like as bad as it is right now. And I do think COVID made that worse. I think we backslid not only in the cafeterias, but in our patient care. Yeah. So it's complicated. Obviously, everything depends on the vendors. It depends on evidence, and there's a lack of evidence for the most part. And this is one of the things that we hope to be pushing towards and building more with our own innovation. Because a lot of times we don't really know what the best practice. We have some ideas. But you touched on an important button, and that is infection prevention. So advice to everybody who wants to work on this: make friends with your infection prevention leadership. Really important that we get on the same page, because healthcare is very risk averse. Infection prevention people are incredibly risk averse because we lose money. We don't get paid as much from CMS, Center for Medicaid and Medicare Services, if we have higher infection rates. So there's a lot of reasons besides the obvious. We don't want to give people infections. There's a lot of energy behind that. But that whole issue of, well, we're causing this other harm as well, that is a culture change item too, because people say, yeah, but this patient's right here with this leg wound, and you're talking about, 30 years from now. This is a place where we need, I think this is work that those of you who work in healthcare can help bridge that gap. And that's why I bring in the concept of planetary health to help people kind of do that. So I think infection prevention is, we have good examples, for instance, reusable isolation gowns. There've been not that many studies, but there are some studies that say not only does it save money, reusable almost always saves money, it's better, more efficacious. It provides better protection and people like it better. We're still not always able to get that done, but that's the kind of evidence we need, and that's an example. Another example of it, and in fact, in the UK, have really been pushing on gloves, not using so many. It has just become a habit. You know, in my earlier days in nursing, we thought skin was pretty good. And it turns out skin is pretty good. And so we don't really need it every time. And so that can be an education thing and a policy thing that we can work on. It's hard though, it really is. This is why I say we can't solve plastics. It is a big enough issue that we need to think of it in terms of plastic stewardship. Are we handling it the right way? Are we avoiding what we can? Are we disposing of it properly to keep it out of soil, air, and water?
We have time for probably one more question.
Still,
Well, you and I were discussing earlier about how to get leadership to care about the issue, because I think you're going to face a different context in different places. And so I'd love to hear your perspective on, for places, if you're struggling to get your leadership to care about the issue, what have you seen have been successful models?
yeah, it can be really hard, and I've been talking with others here for whom it's really hard right now. Oh, sorry. The question is, how do we engage leadership in either committing to this or working to it, or at least not fighting it, you know? And I had a professor once who said, every time you get the answer no, you're one step closer to yes. So I think it's probably pretty good. Because it's we don't all think of it, and it takes some. I do think it's culture change and also education, but certainly a few things are helpful. One, having a mission that's aligned with it. That really helps us, I believe, in Providence, because we have strong language in our documents, our county documents, that we need to care about the environment. That gets us a ways down the road. And then we have leaders right now, and I think, and I was saying this to you, that I think these recent years in the past decade of fires have made a difference in terms of the sense of urgency in California, Washington, and Oregon, particularly where most of our leaders are. I also think you can make the business case, but it's not always convincing or compelling if they can't even pay their bills. I remember one time I talked with a CFO and I had this idea that, well, why don't we put it, you know, if we're not saving this money and we know we're wasting it, I think we need a line item in our budget that says money intentionally wasted. But I asked him about it, but why can't we fix this particular thing when we know we're just paying more and more every month that we need to? He said, and I said something like, if my window was broken at home, I would fix it. He said, not if you didn't have the money to fix the window. So I think this is true. I mean, especially right now, money is really challenging in healthcare. But I think more long-term leaders who are seeing more long-term understand that this is something they need to do. Also, there's a lot of public pressure from our patients, from our staff. And right now there's professional pressure. This is really good news. So for many years, you know, I just longed for, what if the American Hospital Association was supportive of this? Wouldn't that be great? Right now, this last week, they announced their 2023 strategy. Environmental stewardship is on it. First time. And that's because I think the voice, the crescendo is getting louder. The National Academy of Medicine, the Institute for Healthcare Improvement, the Joint Commission, several people, the Joint Commission is probably going to come out with some guidance about this before long. So there has been a sea change at those agency policy ways. So another thing that people say is, did you know the rest of the country is doing this? You know, a little bit of peer pressure. Leaders are really competitive, so we can use that a little bit. I don't have a one size fits all answer, but all of those things can matter. And I think sometimes if you can connect a leader, like an executive with another executive, and they can tell anecdotal stories about, you know, my positions are leaving, you know, or I can't keep nurses coming into the door until we put this on our website, or you know, whatever their experience is. And I wish you all the best with that. We all want to have more and more of our hospitals doing